Hi everyone, and welcome to Unit 8, where we're going to discuss body fluids. One thing about body fluid examination that is different than other types of substances and specimens we've talked about already is that body fluids should be sterile. So there is no normal flora of any kind in a sterile body fluid. In fact, they're called sterile body fluids. The types of fluids we're talking about is cerebrospinal fluid. That's the fluid that surrounds the meninges of the brain. Synovial fluid, which is fluid of the knee. Pleural fluid, which is fluid around the lungs. Pericardial fluid is the fluid around the heart. Peritoneal fluid surrounds the abdominal organs, and then samples from the eye. These are all considered body fluids that we're going to talk about in today's lecture. Let's go ahead and start with cerebrospinal fluid, which is basically a water jacket of the brain and spinal cord. This is fluid that helps cushion the brain, and normally it is clear and colorless. Usually there's about 15 to 45 milligrams per deciliter of protein and about 40 to 80 milligrams per deciliter of glucose in that cerebrospinal fluid, and that of course is for adults. This is usually obtained by lumbar puncture, also known as a spinal tap, and that is when a needle is inserted between the vertebrae. Collection is indicated in patients showing signs of meningeal irritation. Complications of a spinal tap would include things like a headache. In fact, the more spinal fluid they take, the worse off your headache is going to be. You could have a reaction to the antiseptic used, and that's the puncture site irritation, or you could have bleeding into the spinal cord, which is no good whatsoever. All right, so let's go ahead and talk about the laboratory examination of cerebrospinal fluid. First of all, we have to note the total volume collected, and usually what the volume that's collected is between a half a milliliter and 5 milliliters or so. Usually 5 milliliters is quite a bit. We do want to note the macroscopic appearance of the fluid. It should not be red, yellow, milky, cloudy, or fuzzy. If it is yellow, that is called xanthochromic, and it usually indicates some sort of a hemorrhage. We do want to perform a cell count in differential. Polymorphonuclear cells may indicate a bacterial infection, and the cell count for a cerebrospinal fluid should be about 0 to 5 WBCs per cubic millimeter. Chemistry tests would include protein and glucose levels. And if there's bacterial presence in the cerebrospinal fluid, you're going to see that the glucose values go down and the protein values go up. That usually is indicative of a bacterial infection. Then we're going to do serology tests, including things like VDRL, which is Venereal Disease Research Laboratory test for syphilis. And then we can do cytology tests. Usually that's the cytologist that's doing that. They're looking for malignant cells, such as leukemic cells. And then in the microlab, we're going to do bacterial, fungal, viral, and parasitic cultures. So meningitis is an infection of the meninges of the brain, and the meninges are the membrane that covers the brain and the spinal cord. And it's not just Neisseria meningitidis that can cause this. Meningitis can be caused by a variety of organisms, including Streptococcus agalactae, Neisseria meningitidis, Haemophilus influenza, Streptococcus pneumoniae. Those are all things that can cause meningitis. Now, the nice thing about cerebrospinal fluid is that it's a great culture media in and of itself. We never want to refrigerate it, and we always want to hold that spinal fluid at 35 degrees if we can do that, if there's a delay in setup. Now, if you take a look at the image over there on the right, you can see what is the dura mater, which is the layer of the meninges closest to the skull, the arachnoid, which is the middle layer, and the pia mater, which is nearest to the brain. Now, if you go to the emergency room and you complain of these symptoms, you're liable to get a spinal tap. A stiff neck, headache, if you're lethargic, if you have increased intracranial pressure associated with acid-fast bacillus or fungal infections, or you have a rash, and a rash can be associated with more of a viral infection. But any of these types of symptoms may warrant the emergency room doctor to order a spinal tap on you. Now that half a mil to 5 mils of spinal fluid, they're going to put that in several different tubes. And that way those tubes can be aliquoted off for the different departments in the laboratory. Tube 1 is usually used for chemistry assays. Here we're usually looking for protein or glucose levels, and this tube does not need to be sterile, which is why we use tube 1 for chemistry assays. Now, tube 2 or tube 3 is usually used for culture or cell counts. It's often tube 3 that's used for culture because we don't want any skin contaminants that are frequently encountered in tube 1 or tube 2. Okay. Tube 4 is used for serology testing such as herpes testing, rabies testing, syphilis, polio, Coxsackie virus, arboviruses, and things like that. So you might be asking yourself, how exactly do we process cerebrospinal fluid in the laboratory? Well, the first thing we want to do is centrifuge that fluid because we're going to perform cell counts using a cytospin centrifuge, okay? And I'll show you some pictures of that coming up. We're going to spin tubes tubes 2 or 3, keeping the tube sterile, and we use that sediment for culture and acid-fast smears or gram stains. And then this supernatant, which is the liquid portion of the spinal fluid, can be used for additional chemistry or serology testing. Okay. Now, using a cytospin is the standard when we are looking for a cerebrospinal fluid procedure. And I'll show you a picture of a cytospin in the next slide. So the cytospin is a special centrifuge that actually spins the sample down with a funnel in order to concentrate on the cells that we're looking at. So the inside or the outside of the cytospin looks like the bottom left-hand picture, and the inside looks like the bowl that's on the upper right-hand picture. On the upper left-hand side, you can see a funnel with a spring, and what you don't see there is that there is a slide sitting behind that funnel in that metal encasement. What you do is put 4 to 5 drops of spinal fluid in that funnel, and then you put the funnel with the slide in the centrifuge and you spin it down, and what you end up is a concentration of cells in a small circle on the slide. So that's the cytospin. Really good for sterile body fluids where there's not a lot of cells or bacteria. So let's go ahead and compare if a person has a bacterial infection versus a viral infection, okay? In the case of a bacterial infection of cerebrospinal fluid, it's going to be purulent, cloudy, or turbid. There's going to be a high white cell count, and the cells that you're going to see are polymorphonuclear cells. Okay, glucose values are going to be reduced. Remember, a normal cerebrospinal fluid glucose is 40 to 80 milligrams for an adult, and in the case of a bacterial infection, it's going to be less than 40 milligrams per deciliter. In a viral cerebrospinal fluid infection, you're going to see a spinal fluid that is non-purulent and clear looking. Okay, the number of white cells are going to be very low, and if you do see any cells, they're likely to be monocytes or lymphocytes, and your cerebrospinal fluid glucose and protein levels are going to be normal. The glucose level is usually 2/3 that of the serum level. There's a number of different abnormalities you're going to see in cerebrospinal fluid depending on if you have a fungal, mycobacterial, or viral meningitis. And I'll have you take a look at that slide here. But in the case of a fungal infection, the number of polymorphonuclear cells seen is going to be very high. And the same is true with mycobacterial infections. In the case of a viral infection, the number of polymorphonuclear cells are going to be absent or very low. Now, monocytes, sometimes you can see them in fungal or mycobacterial infections, but usually you see them more present in viral infections. If you have a fungal or mycobacterial infection, the glucose level is going to be decreased, but in a viral type of situation, it's going to be normal, okay? And then in the case of protein is going to be increased in a fungal infection. It's also going to be increased in a mycobacterial infection, and it's also going to be increased in a viral infection. And usually that protein level is right around 40 to 80 milligrams per deciliter. That's usually what's normal. Let's talk a little bit about the microbiological examination of cerebrospinal fluid. One thing that they might do in the emergency room is a bacterial antigen test, and this is known as the latex particle agglutination test, or an LPA. Here we're looking for common pathogens that may contaminate the spinal fluid, such as Neisseria meningitidis, strep pneumo, strep B, or Haemophilus influenza. The organism most commonly seen as a cause of meningitis in adults is Streptococcus pneumoniae. We want to do a gram stain examination using a cytospin, and we want to ask ourselves, do we see any organisms on the gram stain? And then we might actually do an acid-fast stain too. Do we see any acid-fast organisms? Do we see any fungal elements? Do we see gram-positive cocci in pairs that are lancets? Those are all things you want to ask yourself when looking at a cerebral spinal fluid gram stain or acid-fast stain. Culturing for routine bacteria, acid-fast bacillus, fungi, and viruses is pretty standard operating procedure for cerebral spinal fluids. We also can do serology tests for increased antibody titers, and then we can also do tests for parasites like Naegleria fowleri. Now, like I said, any organism can cause bacterial meningitis, but let's talk about some of the most common. Haemophilus influenza, Neisseria meningitidis, and Streptococcus pneumoniae and Streptococcus group B are all more commonly seen in infants, especially infants 1 to 23 months. Now, people that are usually a month old or so, if they're going to get a spinal fluid infection, it could be Listeria or E. coli, or even Mycobacterium tuberculosis. A yeast that can contaminate the cerebral spinal fluid is Cryptococcus neoformans. That's usually seen in AIDS patients. Okay, it's associated with pigeon poop, actually. And then there's anaerobes like Peptostreptococcus, Actinomyces, and C. acnes. Clostridium, or I forgot the name of it. Cutibacterium, yeah, they just changed the name. So anaerobes like Peptostreptococcus, Actinomyces, and Cutibacterium acnes are all things that can be seen in bacterial meningitis. And also parasites like Naegleria fowleri is something that can cause bacterial meningitis as well. Sometimes with the cerebral spinal fluid, we have to ask ourselves, is the person hemorrhaging, or is the spinal fluid looking weird because of a traumatic spinal tap? A subarachnoid hemorrhage is very, very serious, and you can see that there's blood evident in the second or third tube. In a traumatic tap, you're not going to have blood that carries over into the second and third tube. Okay, you could have clots in the tube for a traumatic tap, but you're not necessarily going to see clots in the tube with a subarachnoid hemorrhage. Okay, the supernatant, when you spin it down for a subarachnoid hemorrhage, could be xanthochromic, which is yellow. And for a traumatic tap, the supernatant is, once it's spun down and all those cells go to the bottom, is going to be clear and colorless. We always want to look at the second and third tube to make sure there's no blood evident. And if there is in the second and third tube, it's a pretty good indication that our patient has a subarachnoid hemorrhage. Okay. Now, anytime we set up a spinal fluid for culture, we're going to set up these plates. One blood agar in CO2, one blood agar that's anaerobic, one chocolate agar in CO2, one McConkey agar that is aerobic, and finally a thioglycolate broth, and that picks up your anaerobes and any organism that's not there in high numbers. Let's switch gears here and talk about synovial fluid. And synovial fluid is the fluid that cushions the joints. Usually we're talking about knee fluid. Okay? Infections of the joints may occur after bacteremic spread from another site. Infections may develop from a traumatic event, and it may be a bacterial infection or a fungal infection in nature, including Borrelia burgdorferi, which is the organism that causes Lyme disease, or a fungal infection such as one caused by Coccidioides immitis. So how do we handle the synovial fluid when we get it into the laboratory? This is usually first obtained with a needle and syringe, and we want to first do a gross appearance. We want to look at the color and clarity of that synovial fluid. It should be clear and pale yellow. We want to look at the viscosity, and we can do a test known as the Mucin clot test. Synovial fluid should be highly viscous, and in the Mucin clot test, what we can do is put a drop of synovial fluid between our gloved fingers and slowly move our fingers apart about 10 or 20 times. There should be a string that develops, and that's because it's highly viscous. Now, if there's inflammation present, no string is going to develop, and that is a failed Mucin clot test. Okay. We also want to do a microscopic exam for crystals, and we're looking for crystals such as uric acid, which is associated with gout, which is a metabolic arthritis, or we could be looking for other types of crystals as well. We want to do cell counts, cultures, serology testing, especially for rheumatoid arthritis, and cytology testing. A lot of times the cytologist may be looking for rhagocytes, which are neutrophils that contain jagged, engulfed immune complexes, and that is usually seen in rheumatoid arthritis. So there's at least 3 types of synovial fluid categories that are associated with disease. First, we have the inflammatory. This would include things in diseases like gout, rheumatoid arthritis, and systemic lupus erythematosus. Gout is a uric acid metabolic disease, while rheumatoid arthritis is an autoimmune disease that presents with inflammation of the joints. Systemic lupus erythematosus is a chronic systemic autoimmune disease. We could have septic joints, which are joints that are filled with bacteria, fungus, or mycobacterium. And then finally, we could have a hemorrhagic synovial fluid situation where a patient has hemophilia or some sort of trauma. If you remember, hemophilia is a clotting factor disease where coagulation factors 8 or 9 are deficient. So what kind of tubes do we use for the synovial fluid assays? Anytime you're going to do a cell count, we want to keep it liquid, and so we use EDTA. Clot tubes are used for crystal examination and especially rheumatoid arthritis testing. We're going to use the serum for rheumatoid arthritis testing. We can use formalin preservative tubes for cytology exams, okay? And then we can, or some other type of preservative besides formalin. We can use sterile culture tubes, which are used for culture. And a routine culture for a synovial fluid is just like a spinal fluid and other sterile body fluids. We're going to set up a blood agar anaerobically, a blood agar with CO2, a chocolate with CO2, a McConkey aerobically, and finally a thioglycolate broth. Here what I've done on this slide is I've taken the slide and I've compared a normal synovial fluid and then a synovial fluid that's associated with an inflammatory condition, septic joint, and a hemorrhagic issue. And I've compared all of the appearance, viscosity, mucin clot test, WBCs, and crystals. So I'll give you just a few seconds to look this over. But usually a normal fluid is yellow, the viscosity is high, the mucin clot test is good, you have a low number of white cells and no crystals. So here in this image, we've got a couple things going on. We have a normal synovial fluid, which is on kind of the left, or this could be one associated with an inflamed joint as well. It's a little cloudy. The one on the right is more associated with a bloody septic knee. And then we've got some crystals. That top crystal is bifringent monosodium urates, and then down below we have cholesterol crystals. And those are typical crystals that you will see in people that have rheumatoid arthritis or gout. Pleural fluid is the fluid that surrounds the lung, and it may be referred to as a transudate or an exudate. And honestly, for laboratory purposes, we don't necessarily care, but a transudate is fluid that comes from a non-inflammatory origin caused by congestive heart failure or autoimmune disease, where an exudate is a fluid with inflammatory origin, a lung injury, or infection or malignancy. Usually a transudate is from a systemic issue. There's more fluid that is formed and less is absorbed, such as heart failure and cirrhosis. In the case of an exudate, usually we are seeing a fluid that is high in protein, high in cholesterol, and these are seen in patients that have cancer or septic joints or septicemia. Pleural fluid is the fluid that surrounds the lung. The fluid may accumulate between the layers of tissues that line the lungs and chest cavity. And finally, bloody or turbid or putrid exudates may grow things like anaerobes, Streptococcus pneumoniae, and Mycobacterium tuberculosis. Pericardial fluid is the fluid that surrounds the heart. It may be a transudate or an exudate. The fluid actually accumulates around the heart, and often this effusion is viral in nature. Sometimes this is associated with HIV or CMV. Bacterial sources of pericarditis would be Staphylococcus aureus, Haemophilus influenza, Streptococcus pneumoniae, and some non-fermenters. Now, fungal and mycobacterium infections can occur, but they are pretty rare. And 50% of patients with bacterial pericarditis are septic as well. Peritoneal fluid is the abdominal cavity fluid, and it may be a transudate or an exudate. This fluid surrounds the gastrointestinal organs. Peritonitis is usually caused from a perforation in the abdominal wall. A lot of times it is associated with diverticulitis, trauma, or appendicitis. Okay? If you have a burst appendix, this can lead to peritonitis. 26% of intra-abdominal infections are caused by Bacteroides, which is an anaerobic gram-negative rod. 17% are caused by E. coli, and 8% are caused by Streptococcus species. Other miscellaneous species have also been indicated in peritonitis. Let's talk about eye cultures and infections of the eye. First of all, infections of the eye can be minimized by the washing of tears and the antibacterial components of tears. Okay. Remember, there's lysozyme and secretory IgA in tears. Usually both eyes are cultured with a sterile swab or corneal scrapings. The external structures and internal structures of the eye can be cultured. We can culture the conjunctiva, the cornea, which is the eye's window, or the sclera, which is the white of the eye. A large inoculum is desired for eye cultures, and the media we're going to set up is a blood agar anaerobically, a blood agar with CO2, a chocolate agar with CO2, and then some sort of enteric media like MAC, and then a broth media, maybe even Sabs dextrose if we're looking for yeast or fungus, and then possibly a modified Thayer-Martin if we are looking for gonorrhea. The conjunctiva is the mucous membrane that surrounds the eye. Conjunctivitis is when you have an infection of that mucous membrane. It is contagious and both eyes can be affected. Usually you will see red colored eyes, and that is the result of inflammation. Some pathogens of the conjunctiva would be Streptococcus pneumoniae, Streptococcus group A, Haemophilus influenza, Staph aureus, Chlamydia trachomatis, Neisseria gonorrhea, and non-fermenters. Corneal infections include keratitis, which is very painful. This is an infection of the cornea. Viral keratitis, parasitic keratitis, and fungal keratitis are all examples of infections of the cornea. This is more serious than conjunctivitis and may lead to blindness. Some pathogens of the cornea would be Staph aureus, Pseudomonas aeruginosa, Streptococcus pneumoniae, the fuzzies, which are the fungi, enterics, and acanthamoeba, which is a parasite. Endophthalmitis is an infection that affects the interior of the eye, such as the retina, the lens, and the vitreous fluid. Organisms reach the eye via the bloodstream or from a penetrating traumatic eye event. So here's some pictures of things that can actually really hurt your eyes. One would be a herpes ocular infection. Very bad. You can lose your eye or your vision very rapidly. And then on the right we have Pseudomonas aeruginosa, and you can see it actually colors the eye green, much like Pseudomonas itself is green. Pseudomonas infections can actually destroy the eye in less than 72 hours. Below that we have a little child that has a gonorrhea infection in at least one of his eyes, but probably both. Conjunctivitis is spread by airborne organisms, hand-to-eye contact, contaminated cosmetics or medications, and can be easily spread from one eye to the other. Neonatal conjunctivitis contracted via the birth canal with genitourinary secretions could include things like Neisseria gonorrhea. Now finally I want to talk about the miscellaneous wound infections, and this is basically any type of specimen that doesn't fall into the urine, stool, genital, respiratory, or blood culture genre. So these wound infections would include things like soft tissue or deep tissue wounds, surgical wounds, sinus drainages, brain and lung abscesses, inner ear infections, dental abscesses. These would all fall into the wound category, and all wound cultures get anaerobic plates set. Okay? So wound cultures usually require that all organisms be identified, even though some of these organisms may be normal flora. But we do want to line list these, okay? And remember, deep wounds require anaerobic culture. So that is it for Unit 8, where we discuss body fluids such as cerebral spinal fluid, synovial fluid, pleural fluid, pericardial fluid, and peritoneal fluid, and eye infections. If you have any questions, please reach out. Have a good day.